Hi, this is a quick video just about our new X-ray tech note that's being rolled out. It shouldn't be a major change, and hopefully you'll find it pretty straightforward and easy, but I wanted to give a little bit of explanation about what we're doing and why and how to do this. And there's also a PowerPoint presentation that I'm going to send along as well. Basically, some of the fields that have changed. So first of all is this idea of patient stated history. So when you're going to x-ray someone, you naturally talk to them. Just let us know what this is in a very brief form, like patient turned their ankle, or, I'm here just for routine follow-up of my knee. You could say routine follow-up knee replacement or something like that. Very simple things. Laceration. We don't need a whole medical history. We're not expecting anybody to, go into all the past medical history and past surgical history. But anything that is sort of their main complaint, you can put in here. And that's a required field. If you happen to know other stuff, you can put into this other history, the tech history, what says tech history here in this example format. It's always helpful, but it's not necessary. And if you're very busy or whatever, don't worry about it. I wanted to say this is a technical comments. It's just changed its name a little bit. And this is where you put things like where you want to qualify the quality of your images. For instance, you just couldn't get good images because the patient wasn't cooperative or they were obese or whatever. You can put those kinds of comments here. I'd ask you, please don't put them in these history fields, because these fields are going to get imported probably directly into patient reports. So we don't want this to be, ideally you don't use abbreviations. Use things that are clear in these fields, because they're going to enter the reports. You don't want to put some of these things that are going to automatically go in reports. This is more for communication with us, with the radiologists, so you can explain, what's going on if there are difficulties. Most of this stuff's, I think, all there from before. And then the other changes are these three fields here. One is a laterality. And that has to do with it's just a drop-down menu for right, left, bilateral, or not applicable if it's, let's say, a midline structure like the spine or a chest or whatever. And then finally, this is views and images total. And let me explain that briefly. We bill imaging studies based on the number of views of the study. And the views reflect the number of projections that were ordered or asked for by the clinician. So for instance, an AP and lateral is a 2-view study. Now if you have to repeat an image because you didn't cover everything, or it's a little oblique or whatever, that's an additional image, but it really isn't another view. It's really the same view that you've just repeated to try to do a better job. So that can happen either from a quality perspective, or sometimes the body part's too big. Like for instance, if you're looking at the femur and it takes you 2 frontals and 2 laterals to capture the whole femur, but it was ordered as an AP and lateral femur, that's still a 2-view but a 4-image study, if that makes sense. And the reason we do this is we want to be accurate in our billing. You don't want, we radiologists sometimes put in for the number of views too high a number, and that's not right, because then we're billing at too high a number for Medicare or insurance. So we need to get that accurate, and then this is more just how many total images you have. This last part I think is standard for what we already have. So those are the basics. The reason we're doing all this, I should have mentioned at the beginning, has to do both with billing issues and efficiency issues, trying to provide information immediately into our report that can help us to accommodate the larger volume of studies that we're all reading. And lastly, I just wanted to mention the use of arrows is mentioned in the PowerPoint. If you can, if someone, when you talk to them, they can point with a single finger, this is where it hurts. If they can localize their pain or their laceration or whatever, their mass, in a very localized way, please indicate that using an arrow on the screen. Using a radiographic marker arrow. And if you don't have one of those, or you want to use digital arrows, just make sure that in addition to the arrow, it says next to the area of symptoms, because we don't want the clinicians who are looking at these x-rays to think that the radiologist is pointing out an abnormality necessarily. You're really using this to communicate with the radiologist to let us know where the symptoms are. Okay, thank you very much.